Hi guys, we were looking at the respiratory tract infections, right? Among respiratory tract infections, we started with URTIs. In the last section, we started with otitis media. Let us look at the remaining salient features of otitis media. Today, let us start with microbiology of otitis media. So, which all organisms are responsible for the development of otitis media? So here are the few lists of the infectious agents who are responsible for our upper respiratory tract infection otitis media. So most of the cases are due to bacteria, although certain viruses can also result in the development of OM. Anyway, let us see the infectious agents. So here you can see Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, Streptococcus pyogenes, Pseudomonas aeruginosa, influenza virus and rhinovirus are the list of infectious agents that leads to OI. Anyway, let us see the most common bacterial causes of AO. So this is mostly with these first three bacterial agents, that is Streptococcus pneumoniae, Haemophilus influenza and Moraxella catarrhalis. Among these, Streptococcus pneumoniae is the most common bacterial cause for AOM. So it has an incidence of 20 to 35 percentage. How much? 20 to 35 percentage of the AOM cases are due to Streptococcus pneumoniae. And the remaining bacteria such as Haemophilus influenzae and Moraxella catarrhalis, they are also responsible for a minimum, a sizable minority of the cases. Okay, so this non-typable Haemophilus influenzae are responsible for 20 to 30 percentage of the AOM cases, whereas Moraxella catarrhalis are responsible for the development of 20 percentage of the AOM cases. Now, let us see the bacterial organisms that have been associated with less frequently with the OM, such as Staphylococcus aureus, Streptococcus pyogenes, and Pseudomonas aeruginosa. Anyway, viruses are also responsible for the development of OM, right? So, viruses such as influenza virus and rhinoviruses are also responsible for the sizable minority of the AOM cases. In 20 to 30 percentage of the cases, no bacterial or pathogens is found, and in up to 44 percentage, a viral etiology is found with or without concomitant bacteria. Okay, so the bacterial resistance increases with antibiotic usage, such as it is difficult to achieve an appropriate balance between antibiotic prescribing and minimizing the resistance. So while prescribing the antibiotics, we have to take care of the patient uh, safety, as well as we have to minimize the resistance of the bacteria to the antibiotics. Each time antibiotics are administered, the recipient is at increased risk of selection and carriage of the resistant organisms that can be pursued to others. Now, coming to the pathophysiology. So, in this figure, you can see our ear. So, here is the external ear, and from here onwards it's our internal ear. So this portion is the internal ear and this is the external ear, and between this you can see our middle ear. Okay, so our middle ear is connected with the pharynx. So our middle ear is connected with pharynx with the help of this tube. What it is? What is it? Eustachian tube. Okay. So our middle ear is connected to the pharynx through the Eustachian tube, and there is chance of entry of the microbes into the middle ear through this Eustachian tube. Now you may understood what is the route of microbes into our middle ear, right? So otitis media is nothing but the inflammation of middle ear. So which organisms, whatever the organisms that enters the middle ear, that causes the inflammation in this area. Okay, so this is the area where accumulation of the fluid occurs and inflammation occurs in the middle ear. Usually, acute otitis media follows a viral upper respiratory tract infection, right? So this causes the eustachian tube dysfunction as well as the mucosal swelling in the middle ear. So the bacteria and viruses, that is the infectious agents which enters our body through the inhalation of the air, that colonizes our nasopharynx and as well as the oropharynx and laryngopharynx, they can enter the middle ear and they may be not cleared properly by the mucociliary system. So our mucociliary system fails to clear the particulate matter in the inhaled air, and they are able to stick to the middle ear, and thus they bypasses our first line defense mechanism, mucociliary escalator mechanism. So the children are more prone to develop the upper respiratory tract infections such as otitis media. Why? The reason behind it is the anatomy of the eustachian tube is shorter in the children than in adults. Okay, and it is having more horizontal nature, and it facilitate the bacterial entry into the middle ear through the pharynx. So factors such as multifactorial disease process, risk profile, host pathogen interactions, they all are having increased important role in the pathogenesis of otitis media. These events such as repeated viral exposure experienced in a daycare setting or through the exposure to the tobacco smoke, this may all cause the alterations in our mucociliary clearance. So this may stimulate the viral organisms to stay in our middle ear, or it favors the entry of the pathogens into the middle ear, especially in the children with a unique host predisposition. So, AIM typically occurs after an infection that results in increased congestion of the nasopharynx and eustachian tube. So, when as a result of the infection followed by the upper respiratory tract infection, there is increased secretions. So when there is increased secretions are present, what happened? The eustachian tube becomes obstructed, and this obstruction creates the persistent negative pressure within the middle ear. Okay, so you can see, because of the secretions, our eustachian tube is obstructed, and this may result in increased pressure, that is negative pressure within the middle ear. Furthermore, the alterations in the pressure can result in the reflux of the nasopharyngeal contents into the middle ear. So this increase in the pressure promotes the regurgitation of the food materials from the pharynx to the nasal cavity, and this may promote the colonization of the bacteria and viruses in the pharynx, and thus they enter our middle ear. So, the negative pressure can also cause increased vascular permeability, and that can lead to the development of an effusion. So, effusion means that is a liquid, so it can be serous, mucoid, or purulent, or combination of these all. So, in AOM, the effusion contains microorganisms that proliferates in the middle ear and leads to acute symptomatology. So, in the presence of the effusion, the microbes or the infectious agents proliferates in the middle ear and causes the infection. Now let us look at the clinical presentation and a diagnosis that a patient come across after the infection. Generally, acute onset of signs and symptoms of middle ear infection following the cold symptoms such as runny nose, nasal congestion or cough. Now let us see the signs and symptoms of otitis media. So you can see severe pain in the patient, as well as if it is in the children, children may be irritable and tug on the involved ear and have a difficulty sleeping. That means a sudden pull in the ear. So we can see fever in less than 25% of the patients, and mostly fever is present in younger children. So while examining we can see a discolored, thickened and bulging eardrum. So pneumatic otoscopy or tympanometry demonstrates an immobile eardrum. 50% of the cases are bilateral. Pneumatic otoscopy is used to visualize the appearance and mobility of the tympanic membrane, which is suggestive of the presence or the absence of middle ear effusion. Next one is the tympanometry. So tympanometry can also be used to detect the middle ear effusion and or the middle ear pressure. In less than 3% of the patients, we can see the draining of the middle ear fluid. So this usually reveals a bacterial etiology exists. Now coming to the laboratory tests. So we can perform the draining fluids, gram stain culture and sensitivity tests. And if tympanocentesis is performed, then we can also perform the gram stain culture and the sensitivity test of the aspirated fluid. So tympanocentesis is nothing but the reliable method to detect the presence of middle ear effusion. So here we are anestheting the tympanic membrane, and then a tympanocentesis needle is inserted into the tympanic membrane and the fluid is collected, that is the effusion fluid is collected through the tympanocentesis needle. So we can perform the gram stain culture and the sensitivity test of the aspirated fluid, which is collected by the tympanocentesis method. While discussing the classification, I told that we will discuss the definition of each type of the otitis media in after discussing the clinical presentation, right? So AOM is the rapid onset of signs and symptoms such as otalgia, fever. Otalgia means earache or ear pain of acute infection within the middle ear. So, in acute otitis media, we can see the patients are having sudden onset of otalgia and fever. And next one was otitis media with effusion. So, this is the inflammation of the middle ear with a collection of fluid in the middle ear space. And last one was eustache into dysfunction. So in the middle ear disorder that can have symptoms similar to otitis media such as hearing loss, otalgia and tinnitus, but middle ear effusion is usually absent. So now you may be understood Each of these is having almost similar symptoms, but it is difficult to distinguish that. In a nutshell, AOM presents as an acute onset of signs and symptoms of middle ear infection such as otalgia, irritability, tugging on the ear, following the cold symptoms of runny nose, nasal congestion, or cough. So, the resolution of the symptoms of AOM occurs over 1 week. So, pain and fever tend to resolve after 2 to 3 days, with most children becoming asymptomatic at 7 days. Over a period of 1 week, changes in the eardrum normalizes and the pus becomes serous fluid and it becomes normalized. So, initially we discussed that most of the URTs are self-limiting, right? So, how long it persists? The resolution of symptoms of AOM occurs over 1 week. Remember that. So here is the picture for the pneumatic otoscopy. So this is the instrument which is used to visualize the tympanic membranes appearance and mobility. So here is the tympanograph. So we discussed that tympanometry is also used to detect the middle ear effusion, right, or middle ear pressure. So in that we can see graphs like this. So with the help of these graphs are known as tympanographs. So with the help of these graphs we can measure the pressure in the middle ear. So here you can see the images of the tympanic membrane. So the first picture, this one is the picture of the normal eardrum. Okay. So so you can see the malleus sinus staples our bones in the middle ear through this eardrum. So it's a blurred vision, but still you can see our middle ear bones. So this is the normal eardrum, and in this figure, the second figure, so in this figure you can see, in the second figure you can see the bulging of the eardrum. As a result of the infection there existed an effusion, and this resulted in the bulging of the eardrum. And here you cannot see the middle ear bones clearly, so it indicates there exists an infection. Now let us see the treatment for otitis media. How we can manage this otitis media. So what should be our goals? So our goals should be the management of pain and prudent antibiotic use and the prevention of the secondary diseases. So when we are treating AOM, it should be differentiated from otitis media with effusion or chronic otitis media. So generally, otitis media can be reversed with antibiotic therapy. However, choices of which patient should receive antimicrobials, which antimicrobial regimen, and at what point antibiotics should be given after diagnosis, this all should be considered. Generally, otitis media is treated empirically without laboratory tests. Now coming to the non-pharmacologic treatment. So, drugs such as acetaminophen or NSAIDs can be used to relieve pain and malaise in otitis media. We can use tympanostomy tubes. They are also known as T-tubes. So, this is nothing but the surgical insertion. So, this is an effective method for the prevention of recurrent otitis media. So, children with recurrent otitis who have more than 3 episodes in 6 months. 3 episodes in 6 months. So, or 4 or more episodes. 4 or more episodes in a year, they should be considered for the T2 replacement. So, we can consider the T2 tympanostomy tubes or T-tube placement with adenoidectomy. So, this should be considered in the children if the child continues to have episodes of AOM after the extrusion of the original T-tubes. Coming to the pharmacologic treatment. Now let us see how we can manage otitis media with the help of drugs. So, primary prevention with vaccines should be considered. So, there exists a 7-valent pneumococcal conjugate vaccine which should be taken during infancy, and this reduces the occurrence of AOM by 6 to 7 percentage. Okay, so with the help of the vaccination we can reduce the incidence of the disease in infancy up to 6 to 7 percentage, and pain should be addressed with oral analgesics. So analgesics such as acetaminophen or NSAIDs such as ibuprofen, they relieve the pain of AOM. So we should provide a brief observation period. So, this should be considered to determine whether the patient requires immediate antibiotic therapy because of the disease severity or patient characteristics. Antimicrobial therapy is used to treat otitis media. However, a high percentage of the children will be cured with symptomatic treatment alone. Delayed antibiotic treatment, that is 40 to 72 hours, may be considered in children 6 months to 2 years of age if symptoms are not severe and the diagnosis is uncertain, and also in children 2 years of age or older with an uncertain diagnosis. So, this delayed treatment decreases the antibiotic adverse effects as well as it minimizes the bacterial resistance. So, high dose amoxicillin, that is 80 to 90 milligram per kg per day, is the drug of choice for the acute otitis media. If beta-lactamase producing pathogens are suspected or not, such as Haemophilus influenzae, Moraxella catarrhalis, amoxicillin should be given with clavulanate, that is 90 milligram per kg per day of amoxicillin with 6.4 milligram per kg per day of clavulanate in 2 divided doses. So, amoxicillin is considered the drug of choice regardless of the prevalence of drug resistant Streptococcus pneumoniae. Why amoxicillin is considered as the first choice of drug? Amoxicillin has the best pharmacodynamic profile, that is, the time above the minimum inhibitory concentration in the middle ear fluid is for more than 40% of the dosing interval. That is, the drug remains in the middle ear for a prolonged time. So, it is also having a long record of safety and it possesses a narrow spectrum and it is inexpensive. So, this makes the amoxicillin as the first drug of choice. Coming to the antibiotics for the otitis media, let us see the antibiotics which are used for the treatment of otitis media. So we already discussed that amoxicillin is the first choice of drug. Let us see what are the others. Amoxicillin clavulanate, cefdinir, cefuroxime, cefpodoxime, ceftriaxone, azithromycin or clarithromycin is used. So for the first line non-severe cases, we can treat with amoxicillin of dose 80 to 90 mg per kg per day divided twice daily. Whereas for severe cases, we can use the first line agent as the amoxicillin clavulanate with a dose of 90 mg per kg per day of amoxicillin plus 6.4 mg per kg per day of clavulanate divided twice daily. And in case of, if the patient is having non-type 1 allergy, if it is severe, we can treat with cefdinib, cefuroxime, cefpodoxime. And if it is severe, we can treat with ceftriaxone for 1 to 3 days. In case of type 1 allergy, and if it is non-severe, then we can treat with azithromycin and clarithromycin. So, if the treatment failure occurs with amoxicillin, that is failure at 48 to 72 hours, an agent should be considered. That means that should be chosen with the activity against beta-lactamase producing organisms such as Haemophilus influenza and Moraxella catarrhalis, as well as the drug resistant Streptococcus pneumoniae. For example, we can treat with amoxicillin, clavulanate and ceftriaxone. Okay, so here for the first line, non-severe cases, we can treat with amoxicillin clavulanate 90 mg per kg per day of amoxicillin plus 6.4 mg per kg per day of clavulanate divided twice daily. And for first line severe cases as well as for the non-severe type 1 allergy, we can treat with ceftriaxone for 1 to 3 days. And the patients who are having penicillin allergy can be treated with several alternative antibiotics. So here we can use clindamycin for the non-type 1 allergy, that is severe non-type 1 allergy, as well as for non-severe and severe type 1 allergy. So clindamycin can be used in patients who are having penicillin allergy. So hope you all understood. Thank you.